Welcome to the Listen Up podcast, where we explore hearing loss, communication, connections, and health.
Hi, everybody. Dr. Mark Sims here. I'm the host of the Listen Up podcast, where I feature top leaders in healthcare. This episode is brought to you by Listen Up Hearing Center. I help patients to effectively treat their hearing loss so that they can connect better with their friends and family and remain independent. The reason I'm so passionate about hearing loss is because I lost my brother, Robbie, twice. First from his hearing loss from radiation to his brain tumor, and then again when he passed away. I only care for ears. I'm the E of ENT. I've taken care of tens of thousands of patients with nerve hearing loss and done over 10,000 ear surgeries. I'm the founder of Listen Up Hearing Center, and I've also written a book by the same name, Listen Up, A Physician's Guide to Effectively Treating Their Hearing Loss. If you want to learn more about that, you can go to www.listenuphearing.com, 3 W's, and you can learn more about that. I have a great guest today. It's Dr. Chowdhury. She is a cognitive neurologist at Banner Sun Health Research Institute in Sun City, Arizona, which is right near where we are, and a clinical assistant professor at University of Arizona. She completed her medical school at University of Alberta, Canada, followed by a 5-year neurology residency at University of Calgary in Canada as well, and then a fellowship in behavioral neurology at Mayo Clinic Rochester, Minnesota. After all that great training, we're very fortunate to have her here working in our area. Her clinical research includes neurodegenerative dementia, specifically early detection, diagnosis, prognosis with clinical pathologic correlation. Her other passion is education, and she enjoys teaching residents, healthcare professionals in the community about aging and cognition. I was fortunate enough to meet her at a journal club for her residents. It was great for her to have me on. And so I asked her to come back and talk to us. Thanks for coming on, Dr. Chowdhury.
Thank you for having me.
Oh, my pleasure. So tell me a little bit about how you ended up in the cognitive area of neurology. That's essentially would be a right way to say it, correct?
Yeah. So it was interesting because when I started out medicine, I wanted to become a pathologist in medical school. And then from there, I realized that I really enjoyed seeing patients in person and not when they're alive, and I enjoyed the interaction with people and not just looking under microscopes. But I still enjoyed the anatomy component of medicine. So the best place I could really marry those two interests together was neurology. And when I started out in neurology, one of the first decisions you make is whether you want to do central nervous system or peripheral nervous system or both. And I found that I enjoyed the central nervous system more, so the brain a little bit more than I enjoyed the nerves out there. Yeah. I found that cognitive neurology was very anatomically defined. So that continued on my interest for cognitive or anatomy. But more importantly, I really enjoyed working with this population. The more time I spent in geriatrics and behavioral neurology clinics, I realized that cognitive neurology is full of stories, and I really enjoy stories. And most of it is based on timelines and really what people are telling you. And so that was really sort of my drive and interest in exploring it further during residency. And in later years of residency, I also realized that it is a very exciting and up and coming area. I feel that cognitive neurology is where stroke neurology was 30 years ago, where we're trying to convince people that this can actually be treated and taken care of. And people think, no, it's not going to be. And I feel that we're really breaking glass ceilings in this area. And in my career span, I hope to have many, many advances in this field. So that's another very exciting area that drew me here.
Yeah, I would definitely say it's very much for lack of a better word, a hot area in medicine, cognition, right? And so, from the hearing side, it's obviously becoming a big deal with the correlation between treating hearing loss and cognition, which, in hindsight makes total sense. I don't know why we didn't talk about it more. I guess it was evidence or just evolution. So, and that's where our paths cross, obviously, is patients, hearing loss patients' cognition, whether or not your cognitive patients have hearing loss, whether or not our hearing loss patients have cognitive problems, things like that. And so I wanted to talk to you about that in terms of, at our office, we do the MoCA, which is the Montreal Cognitive Assessment, right?
Yeah.
Yeah. And so one of the things I wanted to talk about is, okay, so a patient has a MoCA, and then how is that scored by and large?
So the MoCA has a very standardized scoring system. Most people that administer the MoCA should be trained, so they have an online training system. It is clinically available for free, but if you're going to use it for research purposes, you have to pay them a little subscription fee. However, in the clinical setting, the MoCA can be administered as long as you're trained. They have very specific questions so that people are standardized. They have adjustments for education levels. But despite all of that, the MoCA has its drawbacks, which we can get into later if your audience is interested. But once the MoCA is out of 30, it has several different domains, which tap into different areas of the brain function, including orientation, attention, language, memory, as well as executive function. And patterns can start to emerge in a MoCA or sometimes not, but it is used as a screening exam sort of to see good, bad, big deal.
And so like kind of a positive screen, suggestive of cognitive issue, a positive MoCA, suggestive of cognitive issues, a negative MoCA, suggestive not, correct?
Right. So the cutoff used often is 26. So MoCA below 26 is concerning for cognitive impairment.
Okay. And so let's say somebody, obviously if you test negative, that's good. Right. If you test positive, then, what would be the next step? So what should people, so I'm looking to kind of go through the care pathway in terms of how it all goes. I mean, it's one of those things where, I guess pregnancy would be an example, right? You do a urine pregnancy, then you get a blood pregnancy, then you go see the obstetrician. I mean, there's kind of a pathway of that. So with the MoCA, where would someone go if they had a positive MoCA stream, or where should we send them to go?
Yeah, so this is a little bit challenging on multiple levels because although the MoCA is a good screening test, it is just that, which means that it gets you started, but it does have its nuances. And so you really need a clinician to assess you to start to figure out what is it that's underlying the difficulties you had while you were administered the MoCA. So the best place to start, in my opinion, is the primary care physician, which comes with its challenges. They have their limitations and what they can assess. But there are guidelines by American Geriatric Society, as well as American Academy of Neurology, of where any clinician can start off with a basic workup for someone who comes in with memory concerns and or an abnormal cognitive test. So
for the listeners, like what should they expect if they're trying to do their own due diligence with their primary care? What type of workup would they say, yeah, this is in line with what I should have expected?
So the first thing is to be able to tell your primary care somewhat of a story. Are you concerned? Are you not concerned? What are the main areas of deficits or deficiencies you're feeling in your day-to-day life, and particularly whether that's affecting your function? So are you having to quit your job because of your cognitive deficits? Are you having difficulty managing your finances? So those are big ticket items if you're having difficulty functioning, or if there are safety concerns such as driving, leaving the stove on. These are things that should come to the attention of the primary care physician. And then at the very minimum, the primary care physician would start off with a blood work. So that would include vitamin deficiencies, thyroid problems, common things that can be easily corrected in their office, general blood work, CBC, electrolytes, and then perhaps a little bit more, such as vascular risk factors, so things that have put you at increased risk of stroke or heart attack are good things like cholesterol and liver enzymes, those kinds of things. Other blood work can be done depending on risk factors, and your primary care physician should be able to assess those. And then some level of imaging, so brain imaging. So you can start off as simple as a CT scan or a brain MRI. And really, the field is moving towards using brain MRI just because it gives us more information, not just about the structure of the brain, but also ongoing damage to the brain.
Okay. And so is there a role for rescreening or further diagnostics? I mean, so if you don't, I mean, concern is great if you're aware that there's a problem, but sometimes people have cognitive issues and they're not even aware that they have cognitive issues, correct?
Right. So this is where, having friends and family bring it to your attention is really, really important. So we always recommend that someone who lives with you, who knows you well, or sees you on a regular basis, come to the appointment about cognitive impairment with you. Often they will notice longer and more. And studies have also shown that if an informant or a partner or a collateral historian has concerns for cognition, that correlates much more with true cognitive impairment as well.
Okay. And so that happens. Obviously, if one of the tests come back that could metabolically affect you, that's really wonderful because it's hopefully a correctable problem and things like that. Now, I assume, I'm not an expert, but there are some times where there are one like that all workup comes back negative. Is that right?
Yeah, for the most part, it comes back negative. Thyroid can be off in people sometimes, but I am yet to see fluoride B12 causing complete dementia. However, having said that, if the B12 is abnormal, it should be corrected.
You want everything as optimized as possible, right? Because, those things are modifiable.
Absolutely. And obviously contributes regardless.
Right. Okay. And so what if somebody has that? I mean, I guess what I'm working towards is at some point, some of these patients might end up in your office. So
Yes.
how does that occur, or at what criteria would that occur?
Yeah, so usually the primary care physician gets them started with that basic lab workup. And then if there is concern on MRI or the MRI comes back abnormal, oftentimes they get referred to our clinic. Sometimes, even if the MRI is considered to be appropriate with age, but there is clear decline in function, and often primary care physicians who have known patients for a very long time will notice those changes. They will end up referring them to us or a general neurologist.
So small vessel ischemic disease, is that something to send or not? Because I got to tell you, that's on many, many, many MRIs of people in the last third of their life.
Absolutely. So small vessel ischemic disease is really, really challenging. We know that it can cause cognitive impairment on its own. We know it causes fluctuation in cognitive impairment, particularly attention-related tasks. And what we also know is when it is present with another neurodegenerative condition, which is about 40% of the time in people over the age of 80, it accelerates neurodegeneration. So if someone has cognitive impairment and they have significant small vessel ischemic disease, so moderate or more, then there are two pathways. So the primary care physician can get them started with a neuropsychiatric evaluation. So neuropsychologists often in the community will perform that, and patterns of deficiencies or abnormalities on that test can match up whether small vessel ischemic disease is causing the problem.
So that's going from screening to a diagnostic test to find the specificity of what particular cognitive areas are degenerative or lower or have been compromised. Is that correct?
Yes. So they can get them started there. And certainly if there is moderate to severe amount of disease, they could be evaluated by a neurologist at the very least, to counsel them about vascular risk factors and stroke-reducing factors.
That's what I do tell them, obviously, is to circle back. And then, so that's what if the MRI doesn't have that? So I went down a little bit of a tangent there because I see that finding so much on so many MRIs that, it's kind of one of those things that, you bring the attention to it, but it's almost the rule, not the exception, if that makes sense. But what if the MRI is totally anatomically normal and they come to you and do you get the neuropsychology testing as well to kind of assess their function more in depth?
Yes. So I do neuropsychological testing for multiple reasons. One is if someone is really high functioning, but they have concerns about their cognition, we may not actually detect them on a screening examination.
So by example, they were at a 9 and they've gone down to a 7.5, but the average person is a 6.5 and gone down to a 5. So you don't detect it because they're so high functioning.
That's right. And so if they are really, really concerned, I will send them over to neuropsych evaluation to see if this is a drop for them based on their previous intelligence levels, which can be estimated. The second reason I often send them is to look for patterns in which the various different areas of the brain are where various different brain areas are impacted. And those patterns can give me information about what the underlying process can be.
Oh, so you're reverse engineering it from the deficit. You can kind of figure out what the underlying cause. That's where your anatomy comes into play.
Exactly. So we think that, a lot of these processes are network disruptions in the brain. And based on what areas are involved, we can sort of we can come back and say, okay, well, if the frontal and the parietal regions of the brain are involved, and the frontal parietal network is involved, and those areas are more commonly involved in XYZ degenerative condition.
And then that would put them into a particular category that may or may not lead to therapy on the backside. Is that correct?
Yes. So I always tell people neuropsych evaluation is one piece of the puzzle that will give me information how to put together the rest of the diagnosis. The third reason I send people for neuropsych evaluation is sometimes to get a baseline for future. And the only time I will not send someone to neuropsych evaluation is if they're so impaired that they just cannot sit through the extensive rigorous testing.
Yeah. How long is by just example, it's
about 3 hours.
Wow.
So, and it really does push your brain. It is meant to do that way, to activate various different areas, and it is meant to be exhausting. But it does give us a lot of very useful information.
That's very thorough, I'm sure. So that's great. And so it's kind of, don't jump the gun. Oh, I got a positive MoCA. Let me go get neuropsychology testing. Is what I'm taking here.
Yeah. So not everybody has to go through neuropsychology testing. A lot of times, clinical history is sufficient. So this is where even if you see a general neurologist, it might be benefit. If you get referred from your primary care physician to a general neurology, it might be of benefit because the type of memory complaints or cognitive complaints somebody may have may give us clues about whether this is truly even neurodegenerative. Maybe they're just having seizures, and over time that's causing cognitive decline. Maybe they have other things like multiple sclerosis, and really the cognitive decline is secondary to that, and so on and so forth.
Yeah, it's kind of interesting because, my stumble into this has been backward too. I've had a few patients who have been poorly performing with implantable devices, cochlear implants, and the device is working well, but the whole system's not working well. And by and large, it has been figured out that they have a cognitive issue. And so we've become interested in finding the cognitive issue before we put the implant in, so we can counsel patients better about their potential outcomes.
Absolutely. And that also occurs in other neurodegenerative conditions, which have treatable causes, such as normal pressure hydrocephalus.
Right. So if you find that, you can relieve it and then their cognition gets better. Well, actually, I mean, I'm going down a little bit, but there's actually patients with that who have fluctuating hearing loss too. So it affects the whole brain.
Yes, absolutely.
Okay. And so the other question so that's really great. I appreciate you explaining that whole thing to me. So say somebody either thinks they have dementia or has had a screen that suggests they have dementia, or even, what type of things, I mean, should people do? So, I mean, I know you want to keep your blood pressure right, not have cholesterol, eat right, exercise, those are all those things. But in terms of doing stuff for your brain, are there things you can do? I mean, if you want to make your arms stronger, you lift weights. How do you make your brain stronger?
Right. So there is two things that need to be in balance during for this. One is you can't have you can't have no activity. You do need to activate your brain. So apathy or just no inertia and watching TV all the time really doesn't help your brain. So something needs to happen. So that I usually suggest at least 45 minutes once a day as a starting point as doing a cognitive activity. And that can range from puzzles to Sudoku to, crosswords and whatever they like. But I usually suggest do it regularly. That's really what's important, and establishing a routine is important.
So what I would tell you is somebody I knew would say, oh, I get a lot of exercise. I go out and hang the laundry on the line, which really is an exercise. That's just an activity of daily living. And so what type of activities are there in people's daily living that they would be considered, cognitively, doing that type of equipment? I mean, obviously, I think if you're an accountant, maybe you're doing that all day, but what type of activities do people commonly do that do help work out their cognition?
Right. So something that makes them problem solve is really helps cognition, or something that requires them to go through things in a stepwise fashion. So if someone really enjoys woodworking, I say that's a great thing to do. If someone so that's why crosswords and puzzles and games are so popular. Yeah, because you're problem solving. So those for cognition, those are really good exercises. And then the other thing that has started to show a lot of evidence is music or art therapy. So that's activating sort of the right side of your brain, or the more creative side of your brain. And I usually say do that in the evening because it is usually a more calming activity. However, it does activate the other side of your brain. So those are things. Sorry, go ahead.
Reading? Yeah.
Yeah, reading is good. People like it. I usually say do that before bedtime because then they actually get good sleep. So I often do that. But if somebody really enjoys reading, they can read during the day as well. I try to tell people, find something you really enjoy because they're more likely to stick to it.
But I mean, by analogy, is reading like walking and running is exercise, or is reading really brain exercise? You see what I'm saying? In other words, there's a lot of things that we think are making our brain busy or work out, but it's like walking. It's great. Don't get me wrong, but it's really, you're not getting your heart rate up to where you need to keep your cardiac stamina up. So that's what I'm asking, is reading it or no?
So I usually say, don't read for 5 hours. Like if you're reading all day, that's not exercise. That's not working your brain. If you add in reading in addition to other activity, that's fine. That's exercise because you're just really just doing different things with your brain.
In conversation, is that exercise too?
Yeah. So social activities is exercise, but not in the same manner that we think about doing a crossword puzzle or activating your brain. It really is just activating the more, I would say, it really just is feeding back into your mental health loop and ensuring that you don't have withdrawal. And so that keeps the social part of your brain alive. And that is helpful and has been shown to be good for quality of life overall.
Okay, well, I derailed you a little. So we talked about puzzles and stuff. And what other things would you recommend to people?
So So the other thing I recommend is not overloading your brain. That's a fine line to walk.
Read for 5 hours. That's why you're saying that. Right?
Yeah. And then also not overloading your brain with many things to do. So I often say, if you're going to do stepwise things, remember that your brain doesn't have the same type of cognitive reserve. So if you broke your foot, you wouldn't be running a marathon, although you'd still be walking with it. And so so make sure you reduce your to-do list. So if you did 5 things in a day, do 3 and do one thing at a time. So you have more cognitive energy to give to each task and you can actually get that accomplished.
To avoid some is good, more is better kind of
Yes.
mindset. Like, oh, I'm going to go solve my cognitive problems by doing 47,000 things each day. And that's going to make me better.
That's right. Yeah.
And how about loved ones? What can they do to support, or, I mean, obviously there's the emotional support, but in terms of the cognition, what can they do to help people with it?
So I often tell them that routine is really, really good for your brain. So loved ones can really help establish routine. People with cognitive impairment or dementia often have mood issues and often have motivation issues. And so helping them establish routine, so maybe the loved one can force them to go do a physical activity or an exercise class with them every day. So if they engage with them, often that works really, really well. And the same thing for card games or whatever it is that they're going to engage in an activity, loved ones can really help them engage that. And that often builds into their routine and also increases quality time for the people together.
And so circling back to that, how I know you made mention that how predictive is like a spouse saying that there's somebody slipping, or is that pretty predictive?
It is pretty predictive. I mean, obviously, so there are questionnaires it's called 88, and we often give it to some of our folks who come in through our brain health check-in program, and the participant fills it out as well as their loved ones fill it out. And we know we always weigh the loved ones scores much higher, because if they are noticing a decline, then it's very likely that something is changing about their loved one.
Tell me about the brain check-in program. What does that consist of?
So the Brain Health Check-in program is a free program that anyone can walk in through the door, and we ask them a few questions about their health. We make them fill out a few questionnaires. They also get the MoCA that we just talked about as a screening exam, a couple of other tests, like we look at how many animals they can tell us in a minute, and they also rate their mood. And then at the end of it, we have an algorithm that we put their scores into, and we come up with whether we have a red, yellow, or green level of concern. So like green being no concern and red being a lot of concern. And then they also get some resources. So some of the things we just talked about, diet, physical activity, mood, cognitive activity. So they get counseling about that and resources about that. And then they can take that with them to their primary care physician, because now they've really had the screening exam and a little bit of feedback about how concerned we truly are about their memory.
So how long does a brain health check may take? I want to make sure I got that.
It takes about an hour and a half total.
Oh, that's great.
Yeah. And sometimes when people don't really want to go to doctors and hear that their cognition is declining, and so it also is if someone's really concerned about their loved one, it is also something that they can come without actually seeing a doctor, but kind of get it started. Both the spouse and the partner can come in and kind of do both of them together and then get feedback.
We
separately.
do the same strategy with hearing loss, right? If you think your spouse has hearing loss, why don't you both come in and get a hearing test, and we'll see, which is kind of interesting because oftentimes they both have hearing loss. It's just one's worse than the other.
That's right.
Well, that's great. So that they can get at your research center, right?
Yes, they can come into our clinic and do that.
For people, it's just south of Boswell Hospital. It's on the same campus.
Yes.
So it abuts the Interstate 60. This is local information for people, but that's where it's located. So, well, that's great. You guys have a lot going on, it sounds like, at your center.
We definitely do.
So, And then in terms of your research, you're trying to correlate, obviously anatomically, with these patients, what you're finding clinically, correct?
Right. So we have the advantage of having brain and body donation program that's been around for over 25 years or so. So we also receive donations of brain, and we're able to look at the brain at autopsy. And then we have collected this data for all these years, and we really have the fortunate ability to go back and look at all this data we have collected, whether that's cognitive related, movement related, health related, and really try and correlate them with what we're seeing at autopsy.
That's awesome. That's great stuff. So, well, it sounds like you've got a lot of clinical material for you to delve into, and plenty busy with patients to take care of. So it sounds like you've got a very clinically and academically busy place to be.
Yes, we definitely are. And I think there's not enough of us out there. So
I would agree. I think that's one of the things. So obviously training becomes an essential part of this, because getting enough people as our overall population ages, this is going to be a big thing. So
yes.
So this has been a great primer on cognition. I really appreciate it. So one of the questions I ask all of my guests is, what is your favorite sound? We're in the sound field. So what is your favorite sound?
What is my favorite sound? I think rain. I think the raindrops.
Especially for somebody who lives in the desert, right?
I just moved here, so yes.
Well, it is. I mean, you definitely appreciate it more here, because it's more seldom than it is other places. So that's for sure. And if people wanted to get a hold of you, how would they do that, Dr. Choudhury?
Yeah, so I am physically located at Bannerson Health Research Institute, and our clinic number is 623-832-6530, and that is the main clinic. And so if anyone wanted to have a referral sent here, or they wanted to be able to send questions or whatnot, that would be sort of the main base where they could call in and ask. We also have a banner if folks are interested in educational sessions and seminars. The Banner's Family Community Services has a speakers bureau, and you can just send in a quick email there, and people they're able to find times for us to speak to folks.
That's great. And there's a community newsletter. There's a lot of outreach as well, if I'm not mistaken.
Right. So we have lots of outreach for Sun City specifically, but also other things that I would recommend people look into from educational material is a podcast called Dementia Untangled.
No, that's right. You guys have a podcast. I forgot about that. That's right.
Right. So that's great. And then if you're interested in community newsletters, I would just go to our website, banneralz.org. And then in there, you could just sign up for our newsletters, and you would get our newsletters as well.
That's great. That's really great. This has been Dr. Choudhury. She's a cognitive neurologist at Bannerson Health Research Institute in Sun City, Arizona, and she's a clinical assistant professor at University of Arizona. This has been a great conversation. I'm sure the listenership will want this, and really kind of sets a nice pathway for people to understand where they go next. So thank you so much for coming on.
Thank you so much for having me.
This has been great. Thanks.
Thanks for tuning in to the Listen Up podcast. We'll see you again next time, and be sure to click subscribe to get updates on future episodes.